Welcome to Anatomical Features and Imaging of the Knee Joint. This is Dr. Lin, and let's go ahead and get started. In this session, we'll cover the following learning objectives. The session focuses on correlating knee anatomy with clinical conditions and imaging findings. The knee is a common site of trauma. It's complex mechanics, which must provide stability for weight bearing and mobility for walking. And combined with its exposed location, it's highly likely that it gets injured and also other kinds of pathology. So we'll start off with a little bit on the primary imaging modalities. The first type is the X-ray radiographs. This is very good for diagnosing any bone fractures and also any kind of non-traumatic disorders like osteoarthritis. The second type is called the MRI. This is the best modality for evaluating internal soft tissue problems, usually anything with ligament tears, meniscal damage, and other internal derangements. On the right, you can see a cartoon image of the knee joint. Make sure you know the bones as well as the key bone markings. And we'll go into some of these in the next couple of slides. Here we have the knee anatomy. The primary joint, which is the main weight-bearing joint, is called the femorotibial joint. This is the region where you combine the distal femur with the proximal tibia. The applications here is that the menisci play a very important role for adaptive congruency that helps fill out the spaces so that it fits properly. Damage to the menisci is a common cause of knee pain and also mechanical issues and problems. The associated joints include the patellofemoral joint. This is articulation between the femur and the patella. This joint is oftentimes implicated in any kind of anterior knee pains. The tibiofibular joint, this is the one between the tibia and the fibular head. And on the distal femur, we also have the medial-lateral condyles, which are separated by on the top of the patella surface, where it wedges in, as well as the trochlear groove. The tip right here, the eminence is the protrusion region on the right side of it. You see the medial condyle, and then the lateral condyle. And this is syndesmosis, this interosseous membrane that allows some slight mobility, but not much motion at all. The patella is the body's largest sesamoid bone and is embedded in the quadricep tendon, and its inferior tip is called the apex, which is a key landmark. Then we also have the proximal tibia. One structure to be aware of is the tibial tuberosity. This is the attachment site for the patellar ligament. Then we also have the intercondylar eminence. This is called the tibial spine. This serves as an attachment point for the key cruciate ligaments. And then we have the fibula. The fibula is a non-weight-bearing bone, and its head is an important site for the attachment of the lateral collateral ligament, LCL. Right here we have the head of the fibula, the medial condyle again, the flat grooves of the tibial plateau. Even though it's not perfectly flat, this is important because of the unlocking mechanism, and as a result, the tibia or the fibula will slightly shift based on the locking mechanism, so in open versus closed chain activities. Choosing the correct MRI sequence is critical for understanding the accurate diagnosis. The first one is called T1 weighted images. This is when we have more focus on the anatomy sequence. So in T1 scans or MRIs, the fat appears going to be really bright and the fluid is going to be darker in color. The clinical uses of this is that it's great for displaying anatomical details, making it ideal for visualizing the normal structures on the knee. And then the other type is called the T2. The T2 in comparison is the one that's used mostly for pathology sequences. And as a result, the brightness highlights some pathology. So for example, fluids presented in conditions like edema or inflammation or any kind of joint effusions where the fluid accumulates, it's more sensitive and better in detecting those than T1s. So just remember T1 is for anatomy and T2 is for pathology. On the right is an example of the coronal view of the MRI scan. So you can see some of the key structures like the medial femoral condyle, lateral femoral condyle. The muscles appear darker in gray color. Bones are lighter in white, and then the fat is going to be also lighter in a white color as well, and bright. Over here we have the vastus lateralis muscle, the quads, and over here we have the tibia. And so you can see this is an anterior view of the knee. Let's take a look at the key stabilizers. So we have 4 ligaments that we'll talk about. Damage to these 4 ligaments is a major cause of knee instability and pain. The first one is called the MCL, medial collateral ligament. The main function of this is to resist any kind of valgus stress. Valgus stress is a force that is applied from the outside pushing inwards, so it causes your medial lateral to open up. And it is a key ligament involved in the unhappy triad. Then we have the LCL, the lateral collateral ligament. This one resists the varus stress, which is the force from the inside pushing outward. And then we have, of course, the ACL and PCL. The ACL stands for anterior cruciate ligament. This resists any kind of anterior displacement of the tibia moving forward, so the anterior drawer test can be used to test this. And ACL tears are oftentimes common and significant in sports injuries. And then we have the PCL, which resists the posterior displacement of the tibia. And the PCL tears are a little bit less common, but can result from a direct trauma like a dashboard injury. And we'll talk about the injuries at the end. On the right, a cartoon view of the PCL, shown here. So you can see it comes at the base posterior side of the femur and wraps around the medial aspect, around the upper part of the tibia head. And the ACL over here, kind of on the lateral aspect of the lateral condyle, and then goes down towards the anterior aspect of the tibia and forms a cross. The tibialo-femoral joint. There are types of joints and stabilities. Distal tibial-femoral joint is considered a syndesmosis. This is slightly movable, a joint that is essential for ankle stability, just like the ones you have inside the radius and ulnar. And the clinical relevance here is that the appearance of these ossification centers on a radiograph is based on the age. So different age, you'll see the actual ossification regions on the scan. And the fibular head ossifies at around age 3, and the patella actually ossifies at around age 4. You'll also see that the physial plates, the growth plates, fuse around ages of 16 to 18. And this is important because when you're looking at a pediatric patient, these fractures in the growth plates can tell you the age and what kind of injuries they're more prone to. Now let's take a look at the femoral tibial arthrokinematics. This is important because the mechanics of the knee are clinically important for understanding the function, physical therapy, and the rehab. We'll start with talking a little bit about the key parts of the structures. The femoral condyles have a more protruded convex shape, while the tibial plateau is more flat and concave and it curves in. And as a result, there's going to be this uneven surface between the femur and also the tibia. And as a result of this, there's going to be this concept of the open chain versus the closed chain, and this involves how and which bone begins to move. So in open chain, for example, in a seated knee extension, the concave tibia moves on the convex femur. In a closed chain, let's say you're squatting, so you're putting your feet, planting it down, the convex femur moves on the concave tibia. And so one way to remember this is the chart on the right that I have put together for you. The two main actions are going to be extension and flexion. So in an open chain activity during a tibial movement, what happens during extension of the knee is that the tibia begins to glide anteriorly and externally rotate slightly. Whereas when it flexes, it flips it around. It actually goes posteriorly and it actually glides internally. It glides posteriorly and then it rotates internally. And then when you have a closed chain, like squatting, what happens is extension will be the fibula will glide backwards and they'll internally rotate. And then when you flex, the fibula will then anteriorly glide and then outward rotation. So it just flips around, and this makes it easy to understand what bone is moving and then what bone is going in which direction. And this is important because in rehab, certain actions will strain the ACL a little bit more. So for example, in an open chain extension, you actually strain your ACL a little bit more. Then we also have the screw home mechanism. This is the locking mechanism that has direct clinical applications for the knee stability and rehab. And the function is involved where the knee will lock up during full extension. And it creates a highly stable position for standing with minimal muscle effort. And it locks during flexion. And this is when the popliteus muscle plays a key role for unlocking the knee, allowing it to bend. Let's take a look at the Q angle. Abnormalities of the Q angle are key for clinical finding associated with several knee pathologies. The Q angle reflects the pull of the quadriceps on the patella and is a measurement of the knee alignment. So let's talk a little bit about some of the variations. The measurement goes from the ASIS, the anterior superior iliac spine, to the center of the patella, and from the patella down to the tibial tuberosity. So you do a measurement with a ruler that has the ability to bend, and as a result, the increased Q angle results in what we call genial valgus. This is a condition where the knee tends to knock together. Just remember, valgus sounds like the gum with a G, and gums means it sticks together, so your knees glue together, and this causes the lateral pull on the patella. Increases the risk for conditions like the patellofemoral pain syndrome, what we call PFPS, as well as chondromalacia, which is any kind of weakening and thinning out of the articular cartilage. Then we also have a decrease in the Q angle, which is associated with the genu varum. That's bow-legged, so it opens up. And this increases the load on the medial compartment of the knee, and then it can cause a higher chance of meniscus injury as well as osteoarthritis. So genu varum, bow-legged. On the right, you can see the angle. So for men, it's about 10 degrees, and for women, about 15 to 18 degrees. So anything that is over 20, anything over that the degrees, about 20 degrees, will cause you to have knee knock. That's going to be genu valgum, genu valgus, knee knock. And anything under 10 degrees, where it's almost a straight line or less than 10, you will have bow-legged, where there's going to be opening up, and as a result, there's higher chance of medial meniscus injuries. Now let's start to look at some of the key radiographs. In normal growth in the radiographs, this slide shows you the assessment of how the skeletal matures over different ages. On the first one here, and you'll see the dark contrast background with the bright colored bone. Age 3, the fibular head ossification center is very tiny. It's almost like a small little pebble. And then as you progress to age 9, the growth plates are still open and visible. It's a relatively distinct radiolucent with the dark lines over here. You can see the radiolucent dark lines, but it shouldn't be confused with any kind of fractures, right? So the age plays a big role. By the time you get to age 16, the epiphyseal plates are then fused. And then though they're the remnants of the growth lines that could still be slightly visible, so the growth lines you can kind of see where they were pushing. And this is the whole cartilage to bone model. Over here you can see the head really, really small, faintly right above the shaft of the fibula. And this slide shows you key anatomical landmarks on a normal AP knee x-ray, which is key foundational for understanding fractures. So in this visual, what you're seeing is you're looking at this borderline A, where it represents kind of the placement of the patella. So it should be slightly above the joint space in a healthy individual. There's congruency on left and right side, about the even distance split. Letter B represents a little gap space between the medial and the lateral joint space, should be about equal heights. So if one side is depressed, that could be injury of meniscus. And the last one is the long axis of the femur and the fibula. It should be relatively straight, right? So you want to have it aligned. And those give you a kind of quick visual on how the knee looks. So this is our first key checklist of the radiographic evaluation of the AP view. Key structures that are listed here include the patella, as well as parts of the base on top and the apex on the bottom. We have the medial femoral epicondyle on top, the lateral femoral epicondyle. Make sure you know this anatomical position first. Fibular head and neck, the shaft of the fibula, shaft of the tibia. And right here you can see that the kind of imposed view. So on the right of this view, this is the medial intercondyle tubercle that protrudes out. And on the left of that is on the posterior part, which is the lateral intercondylar tubercle. Then we also have the medial tibial condyle on the tibial side, lateral tibial condyle, and then we also have the femoral condyle of the lateral side and the femoral condyle of the medial side. On the right is a perfect cartoon image that mirrors up to the left. Make sure you study this image. This will be on the exam. Next view that we have here is the lateral view, and this slide details the clinical assessment of a side view. Some of the checklists for the lateral view include, number 1, the patella position. So if you have a really, really high riding patella, we call that patella alta. If you have a very low riding patella, we call that patella baja or infera. And they can be pathological, which we'll talk about. The ratio of that patella ligament length to patella length, patella ligament to patella length should be about 1 to 1. So the ligament and the length of the bone is about the same. In cases where there are joint effusion or any kind of fluid accumulation, you could see that the suprapatellar bursa, usually that little gap, a normal thin kind of a radiolucent dark strip, will tend to become very visible and oval and is filled with fluid. Okay, so some of these gap spaces are going to be the bursas. Over here with the fibula, this is a smaller bone, but just be aware that the A and B, the ligament as well as the bone, should be about equal length in a healthy person. On the fibula on the back here is a small little bone, about 18% will have this, and then a lot of populations will not see it. In this view, the patient usually will have their knee flexed at about 20 degrees, and you can actually look at some of the structures. Some of the key things to be mindful of is that the femoral condyles could be imposed, so they're overlapping, and the tibial condyles are also superimposed as well. Over here we have the lateral view. You can see the femur over here, the patella, the intercondylar eminence of the tibia, that gap, the tibial tuberosity, the tibia, fibular head, the small little sighting of the fibula, as well as the medial femoral condyle on the back, and then the lateral femoral condyle, because this is a lateral view, so you're looking from the outside in. And then on the posterior side of this image, you also see the medial femoral condyle. In comparison to this is we also have an MRI view, T1, and we'll have some MRI scans in a bit, but you'll see over here the fibula bone. Parts of the growth plate shown a lot darker. Patella looks a little bit different as well. It is still kind of bright in color. We also have the fat pads, but most of the fat and the fluids are more visible compared to the bony structures. Now let's take a look at the posterior to anterior view, or we call it the tunnel view, of a radiograph. And the clinical purpose of this is that the view can be taken to get an unobstructed view of the intercondylar fossa. Pathologies can be visualized to evaluate the femorotibial joint space narrowing. Also a key way to look at any early signs of osteoarthritis, or also look for any loose bodies within the fossa. The key structures you can actually see are going to be like your intercondylar fossa, the parts over here, as well as the intercondylar eminence, those two protruded regions, the plateau, really clearly seen, as well as just looking at the joint space and looking for any kind of small fragments. Now let's take a look at the PA axial tunnel view. And this is going from the back, so you can see over here the intercondylar fossa shown here very clearly. Femur bone on top. Over here we have the lateral femoral condyles, the medial femoral condyles, because the fibular head is on the right side of the view, the tibial shaft, and then we also have the medial and lateral condyles of the tibia. Right here is the lateral intercondylar eminence, and then on the left, which is in front on this view, is the medial. Alright, so over here we have the radiologic and also MRI comparison of what we call the tangential view. This is also known as the sunrise view, which is critical for diagnosing patellar instability. It helps us get a direct look at the patellofemoral joint space, and some of the key pathologies that we visualize include patella subluxation as well as dislocations. The limitation, though, is that it only provides really a static view at one angle of flexion and cannot assess the dynamic tracking of the patella, which does require other clinical evaluation. So the first one on the right this is going to be an MRI view, so not X-ray, but you have the intercondylar sulcus shown here. We have the patella shown up top over here. We have the medial femoral condyle over on this side, and then the lateral femoral condyle over here. So this is from a bird's eye view top down. You can see the muscle, bicep femoris, of the quadriceps. And then over here, we can actually see the vessels of the popliteal artery and vein. You can actually see parts of the gastrocnemius head, the calves. And then we also have the semina membranosus, SM, as well as the sartorius over here on the right. The tendinosus will be deeper within. Over here is a view showing you the X-ray version of the tangential on the patellofemoral joint, so you can only see the patella and also parts of the femur where you have that space, the trochlear space. Important that you can measure the angle as well as know that the spacing between is relatively even and distributed. There are some other additional radiographic images for the knee. This one includes the oblique view, which is used to see the condyles without any kind of bony overlaps. So with the internal oblique, the leg is rotated 45 degrees internally, and this will cause you to have the lateral femoral condyle a little bit more visible. And then if you rotate the leg externally, then you will actually see the medial femoral condyle a little bit better. So on the right, you can see in an internal oblique view, you then twist, and you can actually see the lateral condyle a little bit better. And over here, in external oblique rotation, externally rotating 45 degrees, you can see the femoral medial condyle a little better. So you're twisting. And as a result, you can see the movement of the fibula being superimposed. The algorithm for advanced imaging starts with MRI being the best for soft tissue. So in injuries like the ligament tears, meniscal damages, CTs are good for complex fractures. And then ultrasounds can also be used for soft tissue pathologies like tendonitis or bursitis. The key principle here is that you should always correlate the plain radiographs or any of these imaging with patient clinical histories. Now let's take a look at the MRI views. So MRI, we'll start off with the axial plane. And the clinical utility here is that the axial plane is really best used for evaluating any kind of articular cartilage defects, injuries with like the medial patellofemoral ligament, a stabilizer, or even patella reticula. You can also see the tendons very clearly of the pes and serin muscles. So that's going to be the sartorius, gracilis, and tendinosus, and also the popliteus. So let's take a look at this structure. So over here on the right, we can see the reticulum, the medial side, over here. And we can see the lateral reticulum over here, that space where it touches, the little band. The patella in the middle. We have the ligament over here. Ligament right here, that thin yellow dark region. The lateral femoral condyle, the medial femoral condyle. And then we can actually see little bits of cross-section of the pons and seron tendons. It's kind of hard to see which muscles, but the tendinosus would be right here. And the medial collateral ligament will be right here. So they're very thin and slender. All right, the next view over here is going to be the sagittal view. And the sagittal view is a really powerful slicing. It can be help to visualize, especially the ACL and PCL tears, as well as any kind of inflammations of the Hoffman's fat pad. You can also visualize articular cartilage defects and also even bone marrow pathologies, so any kind of bone contusions or infarctions of the bone. So on the right, you can see over here, we have first and foremost the femur. We have also the ACL over here in the back. PCL down here, dark color. Muscle is very dark and gray, the gastrocnemius over here. You can't really tell the long head, short head. And then we have the patella tendon that should be about the same length as the patella. And then we also have this cartilage right behind it. And we also have the Hoffman's fat pad right here that cushions right below and behind the patella. Let's take a closer zoom up of that sagittal plane. So this is a T1 image showing you some key structures. One item that I want to pinpoint is the IPP. This IPP stands for the infrapatellar plica. This is a synovial fold that clinically is oftentimes can be inflamed or cause pain, and leading to something called the plique syndrome. And over here you can see how the transverse ligament, the TL, actually runs transversely through that IPP and also passing the ACL. You can see the TL running through the IPP and also passing parts of the ACL, right? So it's like right in the middle. You can see bigger green arrow running through these two structures. Over here, you can also see the alar folds over here. This little region on the bottom is that coronary ligament, a very small little region. The PCL shown here, the ACL over here, and the IPP is right here. And the TL is the one right in the middle. Now let's take a look at the coronal view of the MRI. The coronal view is best for evaluating structures like the MCL and the LCL, the collateral ligaments. So there's a bright signal for edema where there are sprains or tears. And then also the menisci, which have a high contrast for spotting any kind of cyst, degeneration, or tears. And also looking for articular cartilaginous defects. And also some of the bone bruises as well. So you can see some of the edema patterns or any kind of swelling. So on the right, just a quick MRI coronal view. We have the meniscus, medial meniscus over here. Lateral meniscus over here, and then we have the medial collateral ligament shown here, the dark region, dark band, and then you can see the muscles again in gray, the vastus lateralis, vastus medialis. So let's take a closer zoom. All right, so over here again a T1 plane image, coronal slice showing you the transverse ligament, a TL, transposes through the bones. We have the medial meniscus right here, shown in dark wedge. So when it's healthy, it's nice and dark. And over here, you can see the lateral menisci over here, vastus medialis on the right, and vastus lateralis on the left. Here's another view of the coronal plane. So again, showing you another view from the posterior side. So you can see clearly some of the additional structures that we didn't point out earlier. We have the ACL. We also have the PCL shown here. So these ligaments are nice and dark colored. Over here, we also have some smaller structures like the medial meniscus again, MM, lateral meniscus right here, that wedge. And then we also have the anterior meniscal femoral ligament, also known as the ligament of Humphrey, AML over here, small little ligament, as well as a PML over here on top of it, called the posterior meniscal femoral ligament, called ligament of Wisberg. And these structures are important. These small ligaments are really important, like the ligament of Wisberg over here, a small one on top, plays a role to kind of stabilize that posterior horn of that lateral menisci, and actually binds to the femur and also works along with the PCL. The AML on the bottom of that is similar, but it passes in the front of the PCL and provides more of a secondary restraint to the posterior tibial translation, and it runs from the posterior horn of the lateral meniscus to the anterior region of the PCL. So they work to support this joint region. And we also have another view showing you some of the muscles over here. A really interesting view. You can see the fibular head on the bottom left. We also have the semimembranosus muscle, semitendinosus muscle, the bicep femoris muscle, the gastrocnemius long head over here, gastrocnemius medial head on these two sides. And then we also have three key small ligaments. We have the short posterior genial ligament over here. We have the APL, the arcuate popliteal ligament over here. And we also have the popliteal fibular ligament on the bottom. The short posterior genial ligament, not really standard, but this is also part of the oblique popliteal ligament complex. The main function is to kind of help with the posterior capsular reinforcement. It also kind of blends in with the medial condyle as well as the posterior tibia. Sometimes it's kind of attached near that tibial plateau region. The popliteal ligament on the bottom, which is the oblique popliteal ligament right here, APL, also known as arcuate popliteal ligament. It helps strengthen that posterior capsule. It basically is like an extension that attaches to the semitendinosus tendon, and it runs obliquely. And it does bind to that femoral condyle as well as the posterior capsule. So really their main function is just mostly the capsular reinforcement and also kind of helping to prevent any kind of hyperextension. Now let's take a look at the surgical anatomy of the blood supply. The clinical importance here is that the genicular anastomoses is a network of arteries that provide the collateral circulation to the knee. And this redundancy in the blood supply is vital for healing after traumas or injuries. So let's take a look at the key branches. So we start off with the femoral artery that gives rise to the descending genicular artery. And that then gives off small branches that form the genicular anastomoses. And sometimes it does also give off the saphenous branch towards the skin of the knee. Then we have a big one called the popliteal artery. It breaks out into several key ones. So this one encloses the superior medial genicular artery. We also have the superior lateral genicular artery. We also have the inferior medial genicular artery and the inferior lateral genicular artery. And the last but not the least is the middle genicular artery that you don't see over here. And that one directly goes to the cruciate ligaments and not parts of the skin. But all these four main geniculars form these prepatellar anastomoses, and it helps contribute to all the regions around the femoral head, tibia, and fibular sources. Then we also have the posterior tibial artery that gives rise to the anterior tibial recurrent artery over here. And this one then branches out via the tibial origin, and it goes into the circumflex fibular artery. We also have the anterior tibial artery, which is on the front side. That is going to be kind of a recurrent branch of the anterior tibial branch. And the last one is a small peroneal fibular artery that also helps with the perforate branches towards the proximal tibular femoral region. And these are your main key arteries of the knee. The Schatzer classification of fractures, of the tibial plateau fractures, and this slide provides some clinical classifications of the tibial plateau fractures, and it helps dictate kind of treatment. We're not going to talk about treatment here, but it's important to understand that this classification is used universally by orthopedic surgeons to describe the fracture patterns in guiding surgical planning. The types progress in severity from a more simple split fracture, what we call type 1, to a more complex bicondylar fracture with separation from the shaft. And this is usually as a result of high trauma energy. So the first one, type 1, is where you have this lateral split wedge, usually found in younger patients. Type 2 is where you have a lateral split plus compression. So over here on the top, you also get damage. And type 3 is when you have pure compression fracture on the lateral plateau. So you can see it dips down. Type 4 is a split fracture with the medial plateau being damaged. And in this case, there's some applied varus force. So you can see it breaks off at an angle. And type 5 is what they call bicondylar fracture, where both sides of the tibial plateau are cut off. And type 6 is a dissociation of regions of the metaphysis, that kind of early on growth plate, as well as the diaphysis shaft, where the nutrient is brought to the bone. Next, we also have some articular cartilage injuries that could be occurring. These are called osteochondral fractures. And in a clinical context, these injuries are oftentimes common in young athletes and can result from sports-related shearing, rotation, impact forces. And a transient patellar dislocation is a pretty common mechanism. The pathology here is that there's an osteochondral fragment that can become detached and float freely in the joint, and this acts as what we call a loose body, and it can cause mechanical locking and also further joint damage. So you definitely don't want to have any loose bodies here. The four types you have in letter A is called the osteochondral body with intact articular cartilage, so it's still bound. In the letter B over here, you can see the osteocartilaginous flap that's kind of hanging by a thread. Letter C is when the osteochondral fragment has broken off and broken loose, and then the last one is when it's actually detached off of the bone. Now let's take a look at some of these x-rays that involve these damages. The first kind of injury is called the osteochondritis dissecans, OCD, and this one details the specific cause of knee pain in adolescents. OCD is a condition that primarily affects the adolescents, with about 85% of cases occurring on the medial femoral condyle, and patients simply have more of a dull pain and a chronic effusion that works with activity. Over here, let's take a look at some imaging. Early diagnosis requires MRI to see this fragment because that cartilage does break down later. And also radiographs can show a radiotranslucent line or loose bodies in the joint, and that might be kind of a start. So on the top we have the x-ray, on the bottom we have MRI. You can see kind of a slightly loose region over here in circle. And then in letter B we have the sagittal T1 MRI, and it shows you that there is a little bit of there's a defect present over here. Even though that the articular cartilage is fully intact, we can see there's a little bit of wear over there. The next one is called meniscal tears, and the clinical presentation for this is oftentimes patients will come in with meniscal tears related to intermittent clicking sounds or pain or even effusion. And the most common tear is the medial meniscal tear. And it's oftentimes torn because it's a little bit less mobile and more firmly attached to the capsule and the MCL. A discoid meniscus is when a discoid lateral meniscus is a congenital variant where the meniscus is more of a round instead of a C-shaped, and this is also more likely to prone tears. So over here showing you some examples of the tear. A normal meniscus should be C-shaped. Vertical tear is going to be top down. A bucket tear was when you actually rip it out from one of the edges, so usually the medial side. Peripheral tear is on the outside. A horizontal tear is across, and then a discoid tear is a congenital defect where it's actually going to be more of a round shaped. The gold standard is using MRI. And most of the time, the healthy meniscus is going to be nice and dark, as shown earlier, these wedges. And whenever there are tears, you'll see little kind of rips of bright spots and bright lines around it. Let's take a look at the cruciate ligament ruptures. This is the first one, called the terrible unhappy triad of the knee. The injury pattern, the unhappy triad, is a devastating injury that involves three key structures: the ACL, MCL, and the medial meniscus. And the mechanism of injury is a classical mechanism where there's a lateral blow to an extended and planted knee, which creates this massive valgus rotational force, pushes it in while twisting. In this case, there a complete rupture of the medial collateral ligament. You can see it's not intact. It's a low signal, not bright. Normally it should be nice and bright. The ligament should be giving off a color. Over here in A, you can see a visual showing you the intact stretching by valgus force. So the valgus force from the outside pushing in, and then opens up this cavity on the medial side. And letter B, the unhappy triad. MCL being split, ACL split, and then the MM also split. You can see all three regions being torn. Let's take a look over here at the cruciate ligament rupture. So this slide focuses on the key physical exam findings for the cruciate tears. The clinical exam for the ACL tear is when the rupture of the ACL destabilizes the knee and results in a positive anterior drawer test. This is where the tibia can be pulled forwardly excessive relative to the femur. The clinical exam for the PCL tear will be the opposite. A PCL tear results in a positive posterior drawer sign where the tibia can be pushed backward. ACL tears, ruptures are about 10 times more common than PCLs. On the right, you can see an image of the test. So in the right knee flexion, rupturing of the anterior cruciate ligament where it's cut off. And then in this case, you could do the test where you would actually do the anterior drawer test. You pull the knee forward, and if the tibia can pull forward, that means the ACL has been damaged. If the tibia moves backwards, then that means it would be a PCL tear. Let's take a look at the cruciate ligament tears. So this slide provides the epidemiological and mechanistic details of the cruciate tear. ACL tears are a public issue, about 200,000 per year in the US, and females are almost 8 times more affected than men. And this is due to several combination factors. PCLs are pretty rare, usually caused from a dashboard injury or direct blow anterior tibia. Over here, let's take a look at some of the imaging. Imaging for the sagittal MRI is the best for viewing the ACL and PCL tears. So on the right, you can see a view of the ACL tear, a normal ACL. Shown here, you have the ACL, PCL. You have the ACL and PCL over here. And then when it's torn, you can see that the ACL gets split and the white regions show up a little bit more. On the bottom, we have a normal PCL, the black region right here. And then when it gets split, you can see it kind of snaps off and it's not connected directly to the bone anymore. Now let's take a look at some of the patellar ligament traumas called the apophysitis disorders. And this covers some of the knee pain as well as issues. Apophysitis is inflammation or stress injury to the growth plate where the major tendon attaches. And it's usually caused by repetitive traction forces from the quadricep muscle contracting. As a result, there are two key conditions. The first one is called the Seiding-Larsen-Johansson disease. So for the Seiding-Larsen, the disease occurs over here, inferior to the patella, and then for the Osgood-Schlatter disease, it's going to be at the tibial region. And usually due to repetitive traction forces of the quadriceps, it's going to shift the patella a little bit. So let's take a look at some of the images. So in this case, on the left, we have the Seiding-Larsen-Johansson disease, where you can see the damage and the destruction occurs below the patella. And as a result, the patella might also be shifted a little bit higher. And over here, we have the Osgood-Schlatter disease, where the damage is on the bottom. And as a result, the bulge will be different. So for the Seiding-Larsen disease, the bulge is going to be anterior to the patellar ligament right here. So there's the bulging over here. And then for the Osgood-Schlatter disease, the bulge will be more towards the tibial tubercle.